And gentlemen, good afternoon. I'm Dr. Sang from Beijing Anzhen Hospital. My topic is mapping and ablation of epicardial roof-dependent macro-reentrant tachycardia. Uh, First, so I'm sorry this picture cannot show. I simply introduce the left atrial roof. There are three layers. The epicardial side is septal pulmonary bundle, and the endocardial side is septal atrial bundle. Between SPB and SAB is the adipose tissue, a layer of adipose tissue. So when we do roof line ablation, it is easy to realize conduction block. Once many doctors think it's easier than microisthmus. However, when we use high density mapping to recheck the roof line, there are 1/3 patients have pitfalls. You can see this patient, when placed at left atrial appendage, there is a breakthrough here. So when why this happen? Maybe there are epicardial conduction. Dr. Garcia from UPenn first report epicardial roof-dependent atrial tachycardia after extensive posterior wall ablation. He did entrainment mapping from the anterior wall, septal, and posterior wall. The PPI minus TCL is good, but when he placed at the posterior wall here, when he used 10 MA to place, there is no capture. When he use high output, 50 MA to pace, he can achieve concealed entrainment, which imply epicardial conduction exists. Dr. Rotan has did the epicardial mapping to validate the epicardial conduction. When he do endocardial mapping, it's like a focal atrial tachycardia. But when he did the epicardial mapping, it shows the conduction is continuous. It's a whole circle. In the recent 4 years, we summarized 44 patients with roof-dependent tachycardia. 5 shows epicardial conduction. The patients with epicardial conduction had a longer atrial fibrillation duration, and more of them had a history of posterior wall ablation. We classified the circuit into 3 different types under high-density mapping. 5 patients had the conventional pseudo-focal pattern. From right lateral view, we can say this is clockwise conduction. This one is counterclockwise. And this is bilateral tachycardia because he received extensive septal or anterior ablation. We didn't do epicardial mapping in our patients. We just use indirect evidence to diagnose epicardial roof-dependent atrial tachycardia. The following criteria was used. The first is activation pattern, like pseudofocal activation, and activation around the right pulmonary vein atrium. Many patients have wide, continuous conduction barrier interrupting the airway roof or posterior wall in the endocardial side. The character of electrogram shows a small RS unipolar electrogram indicating epicardial insertion. Far-field epicardial electrogram sometimes recorded. We also do entrainment mapping. PPI minus TCL more than 13 milliseconds at the upstream of the proposed SPB insertion in the left atrial dome. Loss of capture under normal pacing output, and entrainment of epicardial electrograms with increased output. We use entrainment mapping to exclude other possible reentries. Let's say this case. This is a pseudo atrial tachycardia, focal atrial tachycardia. When we do entrainment mapping, the PPI is good at the septal and posterior wall, but it's not good at the left atrial dome. We also can see a large area of slow zone. This is another case which showed a counterclockwise activation. When we do entrant, the PPI is not good at the left atrial dome, but at the anterior wall, here is good. Here is good. The breakthrough side is good. And in this case, we diagnose bioatrial reentry based on the activation mapping and entrainment mapping. At the septal of left right atrium, the PPI is good, and the posterior wall of the left atrium here is good. This patient often received extensive ablation at the anterior wall or the septal wall. So the conduction use the background bundle to conduction to right atrium, like this circle. To mapping and to diagnosis the epicardial roof dependent is not so difficult, but the ablation is challenging. To this patient, we first do reinforcement roof ablation, but only one patient the tachycardia can terminate. Next, we use the floor 9 ablation. We can terminate another 4 patients, another 5 patients. There are 6 patients that cannot terminate, this tachycardia cannot terminate. So we use the anterior wall septal or septal ablation. And there are 3 patients still tachycardia, so we do cardioversion at last. For the esophagus damage, in our patient, the last 3 patients, we use esophagus divination device. After the epicus move to another side, we use 50 watts and achieve AI about 400 450 to 500 AI, we can terminate the tachycardia and achieve achieve block of this line. For this patient, this is the breakthrough site, and the PPI is good, and the PPI at the anterior wall is also good. So the diagnosis is epicardial conduction across the left atrium, the dome. So after we moved the other figures, we do ablation here, and the tachycardia can terminate. Before ablation and after ablation, we checked the figures. There is no damage. This is a case reported recently from Bordeaux. The author used the PFA to do a posterior wall ablation. After 16 PFA pulse, he checked the conduction exists still. Patient the caudal side. And another 12 additional PFA pulse, the posterior wall cannot isolate. So they do martial plan, so martial ethanol infusion. It at last achieved left posterior wall isolation. So PFA maybe cannot damage the asparagus, but it's not so good to do posterior wall ablation. So to do this challenging case, I think maybe there are some way to go to solution this kind of challenging case. Thank you.